Process of apoptosis. In apoptosis, we spoke about the cytotoxic T cells and how it comes, and it has two hands, yeah? So the first hand had the fast receptor, if you remember. So if this is a cytotoxic T cell, look how happy it is. It has two hands. The first hand has what? The gran enzymes, and perforins, which destroys the cells. In the other hand, it has the fast ligand. So what is this? If you remember in apoptosis in cell pathology, we spoke about the following. We spoke how the cytotoxic T cells, this one, the happy guy I'm drawing, he basically did what? He had the gran enzymes which were able to destroy this, basically they are like catalytic enzymes that can destroy the cells. And he has perforins, which makes the channels for the gran enzyme to enter our cells. And if that is true, that means that the cytotoxic T cells can induce apoptosis in cancerous cells. Is that a good thing? Think about it. Is cytotoxic T cells killing cancer cells a good thing? Exactly, it's an amazing thing. So, also the other hand he had was the fast ligand, yes? So his fast ligand activate the fast, which induces caspases and thus lead to the destruction of the cell. Please know what caspase stands for. It stands for cysteine aspartic acid proteases. I know it's ridiculous, but you must know the name. Okay, next one. So the immune checkpoint interactions. So here they write that there are some signals that modulate the T cell activation and function. For dealing with the cancer cells, we need the T cells to be more active or less active? More active. Good. So they write signals that modulate the T cells activation and function decrease the immune response against the tumor cells, which means that there is a few signals that exist from the cancer cells that can lead to inhibition of what? Of your immune cells. And we need to deal with that. Why? Because they are reducing our immune response against the tumor cells. So we need to inhibit that from happening. So let's speak a little bit more about how this happens. So what do we have here? Just a second, let me clean this up. Yep. So here we have a tumor cells, okay? And here we have an antigen presenting cells, and here we have a T cells. And here we have a T cells, yeah? So these three cells are where a person was able to get a Nobel Prize. So let's take a look at it, and hopefully one of you will get a Nobel Prize in the future. So we have an antigen presenting cells, we have a tumor cells, and we have the T cells. Some form of interaction happens between them. You must understand and be comfortable with to be able to know that we invented some drugs that can inhibit some interactions which can increase the immune cells function to destroy the tumor cells. So here is the tumor cell. We want to kill this one, okay? Here is the T cell. We want to activate this one. Good. Here is the antigen presenting cell. Well, this one is also an immune cell that can activate the T cells. So we want it to be functional as well. So let's take a look how it goes. They write for us that there is the following receptor. There is the MHC class 1 and the T cell receptor, as you can see here. And the little thing here in the middle, this is basically an antigen. And an interaction between the two can lead to induction of the T cell. This is a good thing. So the first step here, antigen presenting cells are presenting an antigen that they consumed, and that antigen is presented to whom? The T cells. Let's go one step back, because some of you don't know what is an antigen presenting cells. So an antigen presenting cells, can someone give me an example on them? We have many antigen presenting cells. Someone give me an example, please. Macrophages, okay, what else? B cells, okay, good, what else? dendritic cells. Okay, excellent. So yeah, you have different types of antigen presenting cells. So what is the idea? The idea goes something like this. When a foreign body or foreign material inside of the body, you wanna kill it. The antigen presenting cells come, eat a little bit of it, and be like, "Who? This is my MHC class 2. You must know that the antigen presenting cells have MHC class 2. And all of the other enucleated cells in your body have the MHC class 1, not the class 2. Okay, so the antigen presenting cells is presenting this antigen after it was consumed by the cells, and it's presenting it to the T cell. This is we call T cell receptor. And after that, there is activation of the T cells. They do as well. So if we speak about the antigen presenting cells, you must know that they have MHC class 2 as well. This is vital to know. It's one of the really common question actually. So if you speak about the antigen presenting cells, as you can see, antigen presenting cells have the MHC class 2. Okay, so while the MHC class 1, it's an all enucleated cell except the RBCs. Okay, why? Because the RBCs does not contain nuclei. You'll be like, okay, but the platelet does not contain a nuclei as well. How come they have an MHC class 1? Well, the platelets come from megakaryocyte, which contains big nuclei. And the platelets are just a fracture of that cell. They are not cells by themselves, actually, platelet. They are just a fracture of cells. Okay. So here we have, let's continue with this. So activation of the antigen presenting cells to the T cell, is that a good thing? Yes, okay. So that will lead to the T cell activation. If you have T cell activation, you will kill the tumor cells, which is amazing. That's what you want. Okay, so one more step. Let's go a little bit downward. There is this relationship between the B7 and the CD28. So the B7 activates the CD28, which activates the T cell. Is that a good thing? Yeah, you want the T cells to be active. Remember, our main function is to keep this one active and to kill this one. Okay, while the B7 is inhibited by the CTLA4. Is that a good thing? I'm sorry. The B7, I'm sorry, I made a mistake. Do not say that mistake. What happens exactly that the B7 activates the CTL4. But when this guy gets activated, it inhibits the activation of the T cell. So if you activate the CD28, that stimulates the T cells. If you activate the CTLA, that inhibits the T cells. So would you like the first one or the second one to work? Exactly, you want the first one to work, and you would like to stimulate or inhibit the second one. Inhibit. You don't want him to work, because if he works, he's going to inhibit your T cell activation, which will inhibit the interaction with the tumor cells. Okay, so far so good. Let's keep going. So far we understand the form of interaction between the antigen presenting cells and the T cells. And you just told me you would like to inhibit this guy. Later we will speak about inhibition. To keep going, we have the tumor cell itself have this MHC. Well, think about it. Is the MHC of the tumor cell, will it look normal or abnormal in a tumor cell? Abnormal. It will be really abnormal. It will look weird. And when the immune system will see it, he'll be like, hey, beautiful. It will basically, the MHC class 1 will be presenting, when it will look abnormal, that's one thing. And also it presents some of its internal material. When your normal MHC class 1 presents some of its internal material, it's okay, because it's your own cells. But if it presents cancerous material, the T cell receptor be like, okay, Houston, we have a problem. So the T cell receptor have become active. If it becomes active, what happens? We have the T cell is active, so our friend here come with the gran enzyme, he's the T cell, of course. and the fast receptor, and kill, they kill the tumor cells. Okay, so the last step here, we have something called the BD1 and the BDL1, and which basically the ligand, this is the ligand and this is the receptor. So we have a ligand and the receptor binding to each other, and when this binding occurs, it's basically, look what happens. The tumor cells is super smart. She want to prevent, basically, the tumor cells want to inhibit the T cell activation. How it does that? Multiple mechanisms. But this Nobel Prize was about this exact mechanism. So the tumor cells start making a ligand that works on a receptor on the T cells. That ligand, when it binds to the receptor on the T cells, it inhibits the T cells. So if the tumor cells can inhibit the T cells, will it be able to proliferate more or less the tumor cells? Well, yes, the tumor cells will be able to proliferate more. So does it sound like a good idea to inhibit this ligand or to stimulate it? Would you like to inhibit or inhibit it? You must inhibit it. By the way, for the new members, if you don't know where I'm asking all of these questions, go to the Telegram, open it to the side to your computer and answer the question there. So you are looking at your screen while answering on your phone or another device to the side. Okay, so here we have the following. A guy was like, okay, we isolated the receptors, all of this interaction, we know. Why cannot we make a drug? A drug that can specifically inhibit the bad function in the cell. So he saw that we have we cannot overstimulate the receptor, so we can just inhibit the receptor. So the CTLA4, it led to the inhibition of the T cell activation, which was a bad thing. So if you block that receptor, let's imagine that we blocked that receptor. Will you have more activation of the T cell or less activation of the T cell if you inhibit the CTLA4? More activation of the T receptor. Is this good or bad, guys? Is it good or bad? It's good because it gets you a Nobel Prize. I'm kidding. It's good because it helped the patient. So yeah, so the CTLA4 basically inhibition will lead to more T cell activation, and that will be able to basically kill the tumor cells more effectively. Good. So the next thing, so they made a drug for this. Okay, by the way, let me tell you this. The name of the drug here are super weird. And I don't know, these are drugs from 2018. So they must understand already that students have problem memorizing the names. But they decided to name them in a really weird way. Luckily, they do not ask the exact name on the exam, but they want you to know the mechanism of action, which receptor they bind to. They ask that. They do not ask the name of the drug. But for the sake of completeness, we are going to say the names of the drugs. Keep in mind that anything that ends with MAP, it means it's a monoclonal antibody. Remember, this is an antibodies. So, ipilimumab is the first drug we are going to speak about. This drug inhibits the CTLA4. And yeah, by the way, see this BD, the word, what does it stand for? Program death ligand, program death 1 receptor. So program death. Okay, so let's speak a little bit about the other receptors. So we have these two receptors, and they also, when they interact with each other, you have more inhibition of the T cell activation. So you want to inhibit these guys. How we can inhibit them? By giving atezolizumab, durvalumab, and I like this one, but avelumab. But sadly, it will not work. Basically, the MAB is a monoclonal antibody. And the Zumab and the MAB alone, I will teach you in the future that some of them relate to monoclonal antibody that comes from horse, or monoclonal antibody that comes from rat, or monoclonal antibody that comes from pig. So that's why actually it ends with zumab, mubab, stuff like this. We'll speak about each one individually, but that will be in immunology. Let's leave it for that. Okay, and if we speak about the other one, this guy, it inhibits the receptor itself, like nivolumab and pembrolizumab. I know the names are just horrible. So let's take a look and see if we understand what is written. They write an interaction between the PD1, program death 1, oh here it is. An interaction between the PD1 and the PD ligand 1 and 2 on the tumor cells, here it is, or the immune cells in tumor microenvironment can lead to T cell dysfunction. So when these two bind to each other, they lead to T cell dysfunction. How? By exhaustion. They make the cell pretty tired. So they can be inhibited by an antibodies against the PD1, which is the program death 1, which are these two drugs, pembrolizumab and nivolumab, okay? Or the PDL1, which are the other drugs. So basically, you need to inhibit either this one or this one. For you guys without Anki, it's better to download it now. So CTLA4 receptor, which is located on the T cells, it also can be inhibited. So if you inhibit it, you will have more T cell activation. Why? Because the CTLA4 normally inhibited the cell. So if you inhibit it, you will stimulate the T cells. If the T cell will be stimulated, it will be able to suppress the tumor cells and basically kill it. Yeah? Good. So the CTLA4 on the T cells outcompetes the CD28 for the B7 on the ABCs. What does that even mean? Take a look here, guys. So see the CTL4 and the CD28, both of them binds to the same ligand, which is the B7. So if you have more CD28 than CTLA4, is that a good thing or a bad thing? It's a good thing, yes, because you will have more activation of the T cells. But let's imagine that you have so much ridiculous amount of the CTLA4. That means that you will be consistently inhibiting the T cell activation by two mechanisms, direct inhibition and also stealing the ligand for the activation receptor. So you would like to inhibit this one. So they write, the CTLA4 on the T cells outcompetes for the CD28 for what? The B7 on the antigen presenting cells. So loss of the T cell co-stimulatory signals. What is a co-stimulatory signals? Basically is this attachment, we call it co-stimulatory signals, the interaction between the B7 and the CD28. We'll speak about it when we study immunology really deeply, don't worry about that. So it can be inhibited, this receptor, by the CTLA4 antibody, and when you inhibit it, you will have more activation of the T cells, which can kill the tumor cells. Guys, you see how this guy got a Nobel Prize? It was not that difficult. Yeah, it took us like 20 minutes to explain it. And the poor guy took 20 years. Well, anyway, let's speak about something more important. What is the most common cancer in the world? Do not let this freaking first aid guys trick you. It's not prostate, it's not breast, it's not any of that. The most common cancer is a skin cancer, okay guys? I know that most of the people be like, this is a tricky question. They keep doing it everywhere. So they ask you, what is the most common cancer in man? And you see prostate, and you know that the prostate is most common in men, but between the answer choices, there is a skin cancer. Be super careful about this. Look for the skin cancer. If you find it, that is the answer. It's not a prostate. But if skin cancer is not an option, yes, then it's a prostate. So look what they say. Cancer epidemiology, skin cancer. Basal cell is more than squamous cells and more than melanoma. Is the most common cancer, not included below. Why? Because the most common of the most common. We will speak in the future how basal cell look like, how squamous cell look like, and how can you just look at it for one time and you can diagnose it. Before speaking about it, I just wanna, this picture is from UWorld. I forgot I have it, so let me show you how everything happens. So When you have the programmed death 1 receptor binding to, see, here they write programmed death ligand, programmed death receptor. So when these two bind to each other, there will be an exhaustion of what? Of the T cells, which is bad. It inhibits the T cells. So we made an antibody against this guy, yeah? Monoclonal antibody. That's the main thing they ask. They want you to know the mechanism, not the names of the drug. But for safety, I cannot tell you that they will not ask that. But mostly they will not. You can take the risk. I will if I was in your place. So an anti-CTLA4 monoclonal antibody also can be used, which is can inhibit the CTLA4, which we spoke about here. And its main function of this CTLA4 was what? To overcompete for the B7 and also inhibit the T cell activation. So we inhibit that one as well. And that leads to the tumor cells to be destructed much more often, which means you have a cure of cancer. Guys, I have a question. Does this drug work actually in real life? Oh my God, you guys are really pessimistic. Be a little bit optimistic, come on. Yes, exactly, that's the good answer. In some tumor, it does work, and in some exact tumors, like some forms of lymphoma, it's becoming really common to use these drugs because they actually lead to quite a cure. And that's just awesome because your immune cell is fighting and you give a chance for immune system to fight back. So that's why this guy won the Nobel Prize basically, because for not the first time, we have many treatment of cancer, but it was literally a breakthrough. Okay, let's speak about cancer incidence versus cancer mortality. So the incidence of cancer, the prostate cancer in men is the most common, then comes the lung, then comes the colon and rectum. So let's speak about what is a prostate cancer and what is not a prostate cancer. If they give you a question about a 70-year-old man who comes to you, the doctor, and he tells you, doctor, every night I wake up from my sleep and I go to the bathroom, and while going to the bathroom, I run to the bathroom because I feel like I'm going to be myself. And yeah, I have to wake 3-4 times every night just for the sake of being, urinating, and it's really annoying, doctor. So you wear your glove, and you should wear a glove, you put some gel, and you do a prostatic exam. Digital rectal examination. So you must know how to palpate the prostate. You put your finger inside and you push against the anterior wall. How does a prostate feels like? Guys, now just palpate your nose. If you palpate the tip of your nose, it feels like this cartilage, yeah? This cartilage feels exactly like a prostate. And if you feel that, that's super normal. But if instead of this, you feel that the prostate was diffusely enlarged and it was really soft, but it's big, it's really big but soft. What that means? What do you think? It's really big but soft. It's benign prostatic hyperplasia. So benign prostatic hyperplasia, it can never be cancer. But if you feel it and you feel nodule, like just one nodule on the wall, what is that? So let's say that this is the anterior wall and you feel like the whole thing is big. If the whole thing is big, this is benign prostatic hyperplasia. I agree. But if there is only one nodules here that you can palpate, like if you put your finger here and you feel it like, yeah, there is like a pimple here, and this is abnormal. This is cancer, okay? This is cancer. Okay, so that's for prostate cancer. Really quick question, can benign prostatic hyperplasia become cancer? No, no way, it cannot. It's the only exception. Remember, the only exception for a hyperplasia not becoming cancer. You are right, normally hyperplasia can become cancer, except in the case of benign prostatic hyperplasia. It's the only exception. Okay, so by incidence, the lung cancer is the next most common, but he's the best killer. As you can see, by cancer mortality, he's the best. Well, he kills the most amount of people. While by incidence, he's the second. Why do you think, guys, the cancer mortality is much higher than prostate prostate cancer, regardless of the fact that prostate is much more common. Why do you think? Metastasis is true, but here is the thing. There is only also one more thing: early detection versus late detection. Someone with the prostate cancer, he start having blood in his urine and really horrible pain in his back, and he can have a problem urinating. He will come to you. But someone with lung cancer, he will have the lung cancer for 16 years. He will have no symptoms, and one day he's just feel horrible because there is a lot of space to the cancer to grow, you know. So when you discover the cancer, it will be basically too late. That's why it's the highest killer. And for a prostate cancer, it's easy to detect it. You only need one sophisticated device, your finger. But for lung cancer, you need a CT scan, and that requires insurance. And insurance is expensive, and a lot of people don't do that. So, men, most common cancer is prostate, followed by the lung, and finally we have the colon and the rectal cancer. So, if you speak about women, the most common is the breast, then again the lung and the colon cancer, like men. If you speak about the incidence in children, sadly it's leukemia, which is really bad one, and CNS and neuroblastoma. We'll speak about these in details when we reach them. They say lung cancer incidence has decreased in men, but has not changed significantly in women. Why? Why has the smoke? I gave it away. Why does the lung cancer is becoming less? Why we have less lung cancer year by year? Come on, guys. Nobody know why. Less smoking. Yes. Take a look here, guys. So, of course, we are speaking about the US. You are doing the USMLE exam. So take a look here. If you notice, people now are smoking less. So in the beginning of the previous century, you can see the smokers level, like cigarette sold to adult per day, and it was like less than one cigarette, and it started to increase until the 60s, where everybody used to smoke. 60s and 70s, everybody used to smoke, do cocaine, and everybody was happy. Then what comes? HIV. Oh no, sorry, it comes taxes. So when see, in 1983 the federal tax doubled on cigarettes. So people are like, well, if smoking is really expensive, should I continue smoking? Screw that, I don't want to do this. So it has been decreasing gradually. But guys, what is really important cause of cancer? One of the most important causes of cancer is radon. You are like, wait, what? A substance called radon. You're like, yeah, maybe this is someone who works like in a nuclear factory or something. No, it's not. So radon is basically a substance that exists inside of our houses. You're like, wait, in our houses? Yes, in our houses, also in a nuclear reactor. It's a radioactive substances that mostly located in the basement of the houses, okay? And it's really dangerous. That's why before buying a house, guys, in the future, make sure you check for radon in the basement. There is devices that can check for radon. And if you find radon in that house, it's not worth the money. Do not buy it. There is high chance of people getting lung cancer if they live in that house. So that's one more tip for your future, guys. Okay, so that was lung cancer. And then we have what? We have cancer mortality. The lung cancer is the best killer. Then comes the prostate, then comes the colon. And just a really quick idea, where does the prostate cancer metastasize to most often? The ban? What is ban? Actually, it no. The prostate cancer love to go to the bone. Okay, which bone? The backbone. That's why most patient comes with a complaint of back pain. Lower back pain that is worse at night, doctor. Bone pain worse at night that wakes you up from sleep. That cancer. That is cancer. Okay, guys. So, the next thing, the third most common killer is colon cancer. So in ladies, we have lung cancer, breast cancer, and then come colon and rectal cancer. In children, is the same. So cancer is the second leading cause of death in the US. Heart is the first one. Well, soon the heart one is going down, and then it's going to go, lung diseases are going to go up. It's not COVID actually, it's COPD. Because of COVID, could be bronchiectasis. So anyway, that was general idea about cancers. Now we are going a little bit deeper. So I know that the topic neoplasia is actually a big topic, and I don't like to cover it really quick, just to smash it really quick. No, I will not do that. Now I'm going to explain this page, and then I'm going to start renal with you guys after the break. These pages, each other day, we are going to finish one page, because the neoplasia chapter is super interesting, and we can correlate it with any system we are studying. Thus, I want to give you the maximum amount of time for your brain to absorb all of the knowledge from this one. So here we have the following. Common metastasis. So, sarcoma is a cancer of parenchymal, is sarcoma a cancer of connective tissue or epithelial cells? Come on guys, I want more activity in Telegram. Okay, it's connective tissue. Okay, good. Mesenchyme, excellent. It's mesenchyme, good. What about carcinoma? Is carcinoma is in which type of tissue? Epithelial, good. So most sarcomas spread hematogeneously, while most carcinomas spread via the lymphatics. There is exceptions. Guys, when I tell you that a cancer spreads through lymphatics, do not be tricked. If I speak about the lymphatic system, so there is something called the thoracic duct, yes? So if I tell you a cancer spreads through the lymphatics, eventually where does the lymphatics empty? Where does the thoracic duct empty? The thoracic duct, basically what it does, it collects the lymph from all of your body, as you can see here. It's collecting the blood from all over your body, go up, and then it drains inside of the left subclavian vein. You are like, wait a second. Are you telling me that if a cancer goes to your lymphatics, it will go inside of the lymphatics all the way, and then it will go inside of the blood, and it can become hematogeneous after it was lymphatic? Exactly, that's what I'm telling you guys. So, a cancer that is like basically what they are telling here us in the example here. So the carcinomas that are lymphatics, go through the lymphatics, can eventually go through the blood as well, okay? But there is 4 exceptions, guys. There is 4 exceptions of cancers that go directly hematogeneously and not through the lymphatics. And I will tell you why, because everybody tell you the example, but nobody tells you why. So, however, 4 carcinomas root hematogeneously. The first one is the follicular thyroid carcinoma. The normal question is why. So if you take a look at the lymphatics system, lymphatic system is located all over your body. If you zoom in to the neck, it has basically like a watershed area. It's not reaching there really good. So what happens is that it's closer for the follicular thyroid carcinoma to go directly towards the vessels, which is like the veins of the thyroid, which are, there is quite many of them. So it's easier for them to go there than taking the other way around. So you must know follicular thyroid cancer. So 4 carcinoma root hematogeneously. That was the 4. The next one is choriocarcinoma. Choriocarcinoma is a cancer of which organ, guys? Choriocarcinoma is the cancer of the uterus. Yes. So it's the trophoblastic cells inside of the uterus, okay? And this cancer is super important, guys. It can lead to a huge amount of HCG secretion, and also it can metastasize most commonly to the lung. We call it the cannonball metastasis. I will show you a picture of cannonball metastasis because they tend to like to show you this picture. So cannonball metastasis. As you can see here, guys, it just like boom, it's spread all over the lung. Okay, that's the cannonball metastasis in case of choriocarcinoma. Anyway, that's not our topic for today. Just wanted to show you what is a choriocarcinoma. So it starts from the uterus and it can go to the lung. Okay, so the next one is renal cell carcinoma. Your question, first of all, why choriocarcinoma goes to the blood, not to the lymphatics? Well, guys, if we speak about something called the spiral arteries, I hope you know what is a spiral artery. So spiral arteries are arteries that is located in the endometrium of the lady, okay? These spiral arteries have what? Have really good circulation to whom? To the trophoblastic cells. And where did the choriocarcinoma come from? You guessed it, trophoblastic cells. So it's easier for them to bring the basically the cancerous cells to the basically the blood chain and not to the lymphatics. To go to the lymphatic, it's a long way and the artery is just right there. So I prefer going to the artery. In case of renal cell carcinoma, they go directly to the renal vein. It's much more closer than anything else. And hepatocellular carcinoma, it's also going, you are like, why hepatocellular carcinoma? This is unfair. Well, it has, look, there is a free circulation in the liver. You have your portal vein, but well, that brings blood. Well, that will bring you cancer, not send away cancer. But you have your hepatic vein. Hepatic vein takes the blood from the liver, send it back to the, send it up inside of the inferior vena cava. So that takes the cancer as well. Let's speak about metastasis. So there is a word called the trophism of like cancer to some tissue. And it's basically mean that this type of cancer like that organ and go and bite inside of it. Okay? So it goes something like this. In the brain, we have the most common cancers going to the brain. The most common one is lung. The lung cancer love to go to the brain. And the second most common is the breast, and finally the other one is melanoma. Keep in mind that melanoma loves to go to two organs actually. Which two organs it likes to go to? Except of the brain. Yes, it likes to go to the lung and it likes to go to the... Guys, if you have a... someone asks you, which organ love to get cancers? Just in the heart, right? Atrium of the heart. Excellent. Good. Also in the liver. It likes to go to the liver sometimes. But right atrium of the heart. I wanted to hear that because like we spoke about it. So the brain have the lung, breast, and melanoma. Also colon cancer and kidney cancer can go up there. And can go to the brain. Myxoma is not it's a different form of cancer. Melanoma is metastasis to the heart, and remember, the most common cancer of the heart, is it myxoma or rhabdomyoma, or is it melanoma? Metastasis. Excellent job. Do not be tricked with this. They will write you myxoma, rhabdomyoma, all of that stuff. It's all wrong. It is the metastasis. Okay. So 50% of the brain tumor comes from metastasis, as you can see here. You are like, okay, how can I look at a freaking picture like this and know that this is a metastasis, not a primary tumor? Guys, if you see any organ, this is just a general rule. Of course, it has its exception. But in general, if you take a look at an organ and you have multiple foci of the tumor, not touching each other, as you can see, and these different foci are all over the place, that's a metastatic cancer. If they are connected to each other, this is not a metastatic cancer. But if there is many foci not touching each other, that's high likely a metastatic cancer. If you look at the brain, there is a 3 foci not touching each other. That's metastatic cancer. Okay. So commonly seen as multiple well-circumscribed tumors at the gray-white junction. Why the gray-white junction? It's where the vessel goes. Important thing we will speak about. Guys, do not be afraid if you don't get all of the info from the general neoplasia chapter. Because you will notice when we speak about each organ, we'll speak about its tumors as well. So when we spoke about the heart, we went deeply speaking about, how it happened, like which cancers we had. We had the myxoma, the rhabdomyoma, and all of this stuff. So here it's just general principles you must get. So the liver, the most common cancer comes from the colon. It's due to what? What leads to the cancer to come to the liver from the colon? Which circulation happens between the colon and the liver? Yeah, it's the portal circulation. The portal circulation, it drains your basically colon. It also drains your what? It drains your colon. It drains your many organs. Your stomach, your pancreas. It drains as well. See? So if the patient have cancer of his pancreas, if the patient has cancer of his colon, if the patient has cancer of his stomach, all of these can go to the liver. So you can see colon, stomach, breast, and pancreatic cancer. All of these can go to the liver. Why? Because of the portal system. You must know about the portal system. I'll be asking you about this later today. Okay, so the notes. They write here that liver cancer and lung are the most common sites of metastasis after regional lymph nodes. So, guys, do you remember this TNM staging thing? TNM. What does the N stands for? The lymph node. Yes, excellent. Involvement of lymph node. And the M? Metastasis. Yes, that's correct. What about the T? T. Tumor size and invasiveness. Excellent. Good. So they write here that, yeah, liver is really common place of metastasis. Let's take a look actually here. Picture A, multiple foci. So is it a local cancer or metastasis? Okay, good. Notice, guys, that the metastasis like to go to the gray-white junction. You are like, what? Gray-white what? So you have the cortex is gray matter, guys. And in the future, I will be describing you what is gray matter, what is white matter, just for really quick. I will not take time on this, but if you have neuronal body cells, okay, and they have axons here, okay, you can see the axons. Of course, from the other side, there is like dendrites. Yeah, there is dendrites. So more dendrites. More dendrites. So a collection of the axons, we call it white or gray matter, guys. White or gray matter. We call it white matter. It's white matter. So a collection of the axons, we call it white matter. What about a collection of the bodies of the cells? This we call gray matter. We call it gray matter. Yep. Okay. So we call it this gray matter. As you can see here, in the cortex is gray matter, but here the inner portion, in the future you will understand what is corona radiata, internal capsule, all of that stuff. It's not important now. But between the white matter and the gray matter, if the metastasis occurs at that place, if you have a tumor at that place, this is metastasis. Okay? Okay, good. You see liver here. This is a CT scan of the liver. Is there one foci or multiple foci in this liver? Multiple. So is it metastasis or not metastasis? Excellent, metastasis. And as one person said, and you are completely correct, they are not connecting. Good. Okay, so that what about this gross picture? This gross picture is multiple masses. Yeah? Are they connecting? Are they connecting? No. So it's metastasis. Got it? It's super simple. It does not require a pathologist to diagnose. You just need common sense. Excellent job, guys. So let's see the next one. Bone cancer. Every single cancer in the body loves to go to the bone. But guys, you must be really careful about this one actually. You must take a look at this, okay? And there is some form of bone metastasis that leads to an osteolytic lesion, and some form of bone metastasis that leads to an osteoblastic lesion. So osteolytic lesion, let's take a look at it. So as you can see here, there is a huge decrease in the lucency of the bone. In the head here, you can see it as well. This is a lytic lesion. There is decreased lucency of the bone. And one more for the team. Okay, let's go back here. Speaking about, there is the prostate, breast, kidney, thyroid, lung, many of them. They don't ask this. They want exactly to know which one is lytic and which one is blastic, okay? That's you need to know, you must know. I have two mnemonics, I'm sorry. Well, I did not make these, okay, I did. So anyway, they helped me to memorize them. I know that they are a little bit nasty, but they helped me to keep them straight. So the kind non-lung. So what is this, the kind lung? The TH or for the thyroid, okay? Kind for kidney, non is non-small cell lung cancer. So that reminds me that the kind non-lung, all of these are basically lytic form of lesions. While if we speak about the blastic, it's all of the other ones. So they write here bone metastasis is more than primary bone tumors. For example, in case of multiple myeloma, as someone said. In case of multiple myeloma, it will be lytic or blastic, guys. This is important. In case multiple myeloma, lytic, yes, it will be lytic. Excellent. So yeah, it's one of the most common. It's just like the most common of the most common. And it likes to go to the axial skeleton. You're like, axial what? What is an axial skeleton? Well, guys, your skeleton is composed of two portions. You have your axial skeleton and you have your appendicular skeleton, which means like your main stuff, which is this thing, this is axial skeleton, okay? But if we speak about your appendicular skeleton, is everything else. So the metastases love to go to your axial skeleton. I will be posting a question on this on Telegram after the class, and you must tell me that the cancer like to affect the axial skeleton, not the appendicular skeleton. So as you can see here, you are like, wow, this is cool. So what is this? So basically there is a form of a nuclear study that we do. We give a patient some form of a contrast and we take a picture of him. Well, basically the showing of the bone is bad, but you can see the tumor super good. See? So you can see all of this foci of the tumor. Some people call it the Christmas tree pattern, in which like when you see it, you know that this patient does not have long to live because the cancer is all over the place. So also the blastic one include the prostate and the small cell lung cancers, okay? Of the breast, do not be tricked, it can be both. But let me show you an osteoblastic lung cancer. Sorry, osteoblastic bone cancer. Okay, as you can see here in this picture, there is a what? Increased white. Yeah, so this is what? This is an osteoblastic. Do not be tricked. This patient actually has both. This patient has both osteolytic and osteoblastic. Take a look. So if we speak about, I will line something and you will tell me, is it an osteoblastic lesion or an osteolytic lesion? Sorry, I will make it in red. Is this an osteolytic or osteoblastic lesion? Excellent, this is an osteolytic lesion. What about this one? Excellent, it's a blastic lesion. Good. So let's go back here. You must know that there is the osteoblastic one, prostate cancer, small cell lung cancer, and Hodgkin's lymphoma. And remember the kind none. So that was the thyroid cancer, none Hodgkin's lymphoma, none small cell lung cancer, and renal cell carcinoma. It's the kind. She was kind. And yeah, the multiple myeloma, we just know it. Okay, let's take a look at bone metastasis at different organs. So we saw them in G. Also, you can appreciate here the osteolytic lesion here. Yes, it's osteolytic lesion. And finally, you can see here this mass, osteoblastic lesion forming inside of the humerus. Okay, so let's take a look. I want you to know one more thing. I spoke about lymphatic being the most common pathway for carcinoma to spread. Blood being the most common route for the sarcoma to spread. But there is one more way you need to know about. It's called seeding, okay? So what is this seeding? What does it mean? Well, let me give you an example. Ovarian caking. Okay. So, mental caking. Okay, some people with ovarian cancer can have a spread to the peritoneum, and when it spreads to the peritoneum, it spreads by seeding, in which the tumor just directly go inside of the peritoneum from the ovarian and spread all over the place. We call that seeding. So if you take a look at a gross picture of it, it's a gross picture. So it looks something like this. It's all over the place, as you can see in these pictures. Yep. So we call it omental caking. Why do we call it caking? Why it's called caking? Well, if you cut in a knife, you can see how thick it is. So if you bring a knife and start cutting in it, it's pretty thick. It's like a cake. So yeah, enjoy this picture. I hope you had cake today, guys. Okay, so that's omental caking, and if they ask you why it happened, you must not say it's due to the seeding process. Okay, so now we are done with neoplasia for the day. Let me just share my screen, and here we go. Renal. Okay, guys, get a little bit energized. Neoplasia made you a little bit sleepy. So let's start with renal. The embryology of the kidney is a really important subject. It's much more relevant for clinical problems than other systems. So if we speak about the kidney embryology, you must know that during initial phases inside of our mother womb, some stuff happens. You know that the amniotic fluid around the baby, where is it produced? You know that baby is swimming inside of amniotic fluid. So that amniotic fluid, where it is produced? What weird type of fetish is this? Do you mean that seriously? So the baby is swimming in his own urine? Yes, he is. So actually, the fluid, the amniotic fluid around the baby, this is the urine of the baby. Wait a second. So, well, how can we reduce that? Because the baby keeps being. How can we decrease the amount of that B around him, basically, or that urine around him, or amniotic fluid? We can. The baby can. He swallow it. Okay, he swallow it. That's nasty. So the baby bees and then it drinks his bee, exactly, and then it goes through his GI tract, get absorbed and bees again. Okay, so it circulate. So the bee go from the baby. So if this is the baby, he bees, it fills the amniotic fluid, and then he drinks it again, and it goes inside of his body. Why this is important? If the patient does not have a kidney, if the patient cannot basically does not have a kidney, will he be able to urinate? Well, if he does not have a kidney, he will have low amount of amniotic fluid, almost zero. So you can imagine that the amniotic sac will be collapsed. It will be much more smaller. Okay, if we say the patient cannot swallow, he cannot swallow. Let's say he has like an atresia of his esophagus, or he has absence of the of where the swallowing center in his brain is absent. So what will happen? Will he have more amniotic fluid or less amniotic fluid? Okay, no, actually more. Look, if you cannot swallow the amniotic fluid, you will not be able to clear it. So it will accumulate, yes? If it accumulates, we call that polyhydramnios, okay? Good. So there will be more amniotic fluid. Okay, if the patient has a strictures in his ureter, will he have more amniotic fluid or less? A stricture in the ureter, it's basically like, if this is the ureter, it has a blockage in his ureter. Will he have more amniotic fluid or less? The answer is less. Okay, good. So let's take a look. I just give you a general idea just to keep in mind what I will be speaking about. If we speak about the kidney embryology itself, the kidney, the word nephros means kidney, okay? Anything that is nephro means kidney, anything that is ren also means kidney. So we have the pronephros, which occurs at week 4 and then degrade and you never see it again and it's clinically irrelevant. But you have a structure called mesonephros. Mesonephros. The word meso in Latin means middle or midway. So if we speak like mesonephros is in the between kidney. If we say mesencephalon is the midbrain. So mesonephros is super important. It functions as a kidney for the first trimester of the baby. You're like, what is the first trimester? Well, a pregnancy is consistent of 3 trimesters, okay? So we have the first, second, and third trimester. So like each is around roughly 3 months. Good? So at first 3 months, this is the first trimester. Second 3 months, this is the second trimester. Third 3 months, this is the third trimester. And in the first trimester, your mesonephros is acting as your kidney. So it functions as an interim kidney for the first trimester and later contribute to the male genital system. Please add this note. The mesonephros makes the vast difference in the men. So it's important to know about the vast difference. So this vast difference, as you can see here, it's also has, yeah, here it is. So this is the vast difference, which basically transport the sperm, okay? So that help you in the formation of it's formed from what? Mesonephros. Mesonephros make you the vast difference in men. Guys, do you know which disease has absence of vast difference? The patient does not have vast difference in that disease. Well, you must know this. The vast difference, yes, he will be infertile, but what is the cause? In cystic fibrosis, the patient will not have vast difference. You must know this. A patient with absence of the vast difference has cystic fibrosis, okay? So let's go back here. And he will be infertile. Well, a question will be, he does not have the vast difference that basically transport the sperm. So if you do IVF, which is in vitro fertilization, see, this is the vast difference, it will be absent in someone with cystic fibrosis. So if you do in vitro fertilization, will he be able to make a lady pregnant? Yeah, of course he can, because it's just mechanics, yeah? You just take the sperm directly from the testicle and inject it inside of the oocyte. That's it. Okay, let's go back here. So here we have the metanephros. It's permanent. So it starts appearing around the 5th week of gestation. You are like, oh, so how many weeks is gestation? 40 weeks, guys. 40 weeks is 9 months. Nephrogenesis continue throughout the 32 to 36 weeks of gestation. What is important for you to know, guys? The important stuff to know that the metanephros has subparts. So the first part include the ureteric bud, second part is the metanephric mesenchyme, and the third thing we'll speak about it later is the junction. So what is this ureteric bud? The ureteric bud is just like a duct here, as you can see, and the mesenchyme is here, the metanephric mesenchyme. It's important. So this looks like a small ureter, and this looks like a small kidney, and you will know why I said these words just now. So the ureteric bud, it's also called a metanephric diverticulum. It comes from the caudal end from the mesonephros. The mesonephros, as you can see, here it is. Then it brings a small portion called the ureteric bud. Do not be tricked. It's a portion of the metanephros, not the mesonephros, regardless of the fact that it's derived from the mesonephros. So, what does it give rise to? It gives rise for the following structure. It gives rise to your everything, distal to proximal. So, that will be the ureter, the pelvises, the calyces, the collecting duct. So, you are like, wait a second. If I start from the glomerulus, here we have the afferent arteriole, here we have the glomerulus, and here we have the efferent arteriole. So if I speak about like the glomerulus like this, we are going down, we have the proximal tubule, we have the lobe of Henle, we have the distal tubule, and after having the distal tubule, we have the collecting duct, yeah? The collecting duct basically gets so many other ducts, and all of them form the collecting duct. So so it will be something like this, many ducts join. Yes, so this is the collecting duct. Okay, so anything from the red line and after comes from the ureteric bud, including the collecting duct, including the renal calyces. So you are like, renal what? Renal calyces. So what is a renal calyx? A renal calyx is this portion of the kidney that is right here. We call this a renal calyx. When the renal calyx combine with each other, they make renal pelvis. When the renal pelvis continue, it make you the ureter. When the ureter continues, it keep going downward until it reaches the bladder. After it reaches the bladder, it gives an urethra. An urethra goes outside. So, ureteric bud, it's called metanephric diverticulum. It's derived from the caudal end of the mesonephric duct and give rise to the ureter, pelvises, calyces, and collecting duct. Fully canalizes by 10th week. So if I ask you, what gives the origin of vas difference? Is it the pronephros, mesonephros, or metanephros? Yes, it's the mesonephros. Okay, so in the future I will keep tricking you about this ones. So the metanephric mesenchyme, its metanephric blastema is synonyms. As you can see, it looks like a small kidney, yes? So they write, ureteric bud interact with this tissue, and interaction lead to differentiation and formation of the glomerulus throughout the distal duct. What does that mean? So an interaction between this parenchyme, the metanephric mesenchyme, and the ureteric bud makes you what? Everything proximal to this line. So it gives you your distal convoluted duct. It gives you the lobe of Henle. It gives you your BCT. It gives you your glomerulus. What gives me all of that? That is given for you by the metanephric mesenchyme. This one that looks like a kidney. Yeah? While your ureteric bud gives you everything after it, like it gave you your collecting duct, it gave you your collecting duct, calyces, pelvises, ureter, all of these were given by the ureteric bud. Okay, so as you can see here, the metanephric mesenchyme, metanephric blastema, ureteric bud interacts with this tissue, and this interaction induces differentiation and formation of the glomeruli throughout to the distal convoluted tubule. So an aberrant interaction between these two tissues may result in several congenital anomalies, including renal agenesis and multicystic dysplastic kidney disease. Why? Guys, if this connection and interaction between these two tissues does not occur, if it does not occur, you can imagine what can occur. If it's not happening, you will not have formation of anything proximal to this line. So all of this will not happen. All of this tissue will disappear. So that will lead to agenesis of the kidney. Or even you can have something else. If poor interaction happens and bad connection between them occur, you can have formation of cyst in between them, yes? And if you have multiple cysts at different portion, at different like glomeruli, you can have what? You can have multicystic dysplastic kidney, a disease that we are going to speak about today. So the next point is uretropelvic junction. And this uretropelvic junction is the last portion to canalize. And let's take a look at where it is located. So this is the ureter and this is the pelvis. And this is called the uretropelvic junction. So if we Google so the uretropelvic junction is this one. So you can imagine that this is the last portion to canalize. So if it does not canalize well, you will have obstruction, and that obstruction can lead to hydronephrosis. So hydronephrosis means a backflow of the urine against the kidney. So apparent interaction between these two tissues may result in several congenital malformation of the kidney, including renal agenesis, multicystic dysplastic kidney. An uretropelvic junction is the last to canalize and can lead to a congenital obstruction, as you saw in the picture. So let me just add this picture because it's actually important. So speaking about this, they write most common cause of a prenatal hydronephrosis, and you can see why. It's detected on a prenatal ultrasound. You will basically see a back mass of urine. So again, now time of the questions. Can you tell me, guys, what portion of your kidney gives you your collecting duct? The ureteric pod. Excellent. It's the ureteric pod. Which portion of your kidney give you your distal convoluted duct? Metanephric mesenchyme. Okay, good. Which portion of your kidney give you your calyces of your kidney? The calyx of the kidney. It's by the butt. Okay, good. What about glomerulus? Okay, excellent. Excellent. Now we are going to speak about Potter sequence. Potter sequence happens due to basically oligohydramnios, which is decreased amount of the amniotic fluid. We said that the amniotic fluid is the pee of the baby. So will you have less amniotic fluid if you have a problem in the swallowing of the amniotic fluid or having a problem in the kidney? Kidney, yes, exactly. So if you have a problem in the kidney, you cannot be out the what? You cannot be out the amniotic fluid, and thus it will start basically reducing because you are not producing a new amniotic fluid. So that leads to oligohydramnios. So if you have oligohydramnios, what will happen to this poor baby? Let's take a look. So we have a baby. So the amniotic fluid have many functions. Yes, it's true that it has some healing substances, blah, 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 but one of the main things that it keeps the baby like swimming, yeah? To protect him. If he gets a trauma, see the amniotic fluid moves, yeah? It's like jelly. So it moves all over the time. But if we say that the patient have polyhydramnios, you have a lot of it. But if you have oligohydramnios, you have little of it. If I even make it really, really small, this poor baby will be squeezed, yeah? So let me squeeze him. So you can see how he's going to get squeezed. So that's compressing his face. Yeah, I'm compressing the baby. So if I keep compressing this baby, he will get something called the Potter sequence. What does it mean, sequence? Sequence, it's a one initial pathology that leads to sequence of pathologies. So it's one problem that leads to multiple problems. Let me tell you what I mean by that. So the sequence here that the patient has oligohydramnios. The next step of the sequence is compression of the developing fetus. Due to the compression of the developing fetus, you will have limb deformities. So you see the sequence? You have one step leading to another step leading to another step. So the patient does not have limbs, not because of the oligohydramnios, but because of the compression. So limb deformities, facial anomalies as well, like low-set ears and retrognathia. Retrognathia means that your jaw is going backward, okay? And the flattened nose as well because of the compression. Also, compression of the chest and lack of amniotic fluid aspiration into the fetal lung can lead to pulmonary hypoplasia. You are like, wait a second, what does that mean? Well, your lung, your alveoles, normally during infancy, what do they have inside of them? Like your alveoles when you are inside of the mother womb, inside of the uterus, what do they have inside of them? Fluid, yes, amniotic fluid. They are filled with amniotic fluid. And when they have all of this amniotic fluid inside of them, it is a good thing or a bad thing during embryology. It's really good because it keeps the alveole big. Yes, it dilates it. So in the future, when it will empty this fluid from the inside, there will be a place for the air to come in. Yeah. So this is super important. And yeah, exactly, prevent the collapse. So here is the idea. If we say that this patient with this problem, which is Potter sequence, has reduced amniotic fluid, what will happen to this alveole in the mother womb? It will start to collapse on itself, yeah, because so it will start to collapse. It will become much more smaller. Be like, oh well, there is nothing inside, so let me just shut down. Yep. So you can see here what they write. They write compression of the chest and lack of amniotic aspiration into the lungs lead to pulmonary hypoplasia, which is the cause of death. You must know that the cause of death is pulmonary hypoplasia. Okay, so what can lead to dysfunctional kidney in the baby? Well, if you have absence of one kidney, can you get Potter sequence? No, because the other kidney will produce you the amniotic fluid. That's correct. So you need diseases that affect both sides. Yeah. For example, a disease called autosomal recessive polycystic kidney disease. Why autosomal dominant polycystic kidney disease is not an option? Because autosomal dominant polycystic kidney disease has late presentation, while autosomal recessive polycystic kidney disease has early presentation. I'm going to tell you a secret, guys. All of the autosomal dominant disease have late presentation. It doesn't matter what is the disease. If we speak about von Gerke disease, it's an autosomal dominant disease. It has late presentation. If we speak about ALS, it's an autosomal dominant disease. It has late presentation. If you speak about retinoblastoma, autosomal dominant, late presentation. Okay, so autosomal recessive polycystic kidney disease, also obstructive neuropathy. For example, in the posterior urethral valves. Make a note. This disease can only occur in males. It never can be in females. Okay? So only in males. Posterior urethral valves can be only in males. So you can see that the problem in this disease that as you can see, this tissue, there will be extrinsic tissue located at the urethra. And when it... My sound? I'm not sure. Can you hear me normally, guys? Can you hear me? No. Oh, okay. You cannot hear. Can you or you cannot? This is... Okay, guys, if you can hear me, please write yes. Okay, excellent. So, in case of the urethra having an occlusion, we call and basically formation of a one-sided valve, we call that what? Posterior urethral valves. In the future, I will describe them deeper, but I just want you to know that this basically lead to an outflow obstruction. And if there is an outflow obstruction, then you will have less making of the amniotic fluid. Thus, the patient will get water sequence. Bilateral renal agenesis, same deal. Chronic placental insufficiency. What is chronic placental insufficiency? Well, you remember that the blood is supplied to the baby by the placenta. So, if the baby has chronic placental insufficiency, which is lack of blood supplyment to the baby, if the baby has less blood supply, the kidney of the baby will have more blood supply or less blood supply. Less blood coming to the baby means less blood going to the kidney of the baby. Thus, the baby can have what? Less making of the amniotic fluid, and thus he can have compression of the developing fetus and limb deformities, retrognathia, and pulmonary hypoplasia, all of the Potter sequence stuff. So baby who cannot be on utero develop Potter sequence. So what is the Potter sequence? It includes the following. Oligohydramnios, which is because I told you sequence, it means one pathology that leads to multiple pathologies. So the first one actually is oligohydramnios. That's the trigger. That can lead to twisted faces, twisted skins, and extremity defects. Renal failure in utero can lead to all of this. And as a consequence, you also can get the killer, which is pulmonary hypoplasia. I just want to show you a few pictures of Potter sequence. So if they show you a gross picture of it, you will be comfortable taking a look at it. So you can appreciate the retrognathia this patient has. It's going back. Look at his extremities. They look tested. And his skin looked messed up. So another picture. Look at this poor development of the fingers. Retrognathia. Nose is pushed. And yeah. Okay. So what the... Anyway, look at this guy. He has retrognathia, flattened face, all of that. So this is symptoms of Potter sequence, regardless of the fact that he's made out of mud. Yeah, it can be detected in utero. And if you detect it in utero, actually you can prevent it by injecting amniotic fluid. So, well, you are like, can I inject amniotic fluid? Well, not really. We inject fake amniotic fluid, normal saline, but still better than nothing. So, okay. So the next thing. Oh. I see. Okay. Where was it? Oh, here it is. No problemo. So here we go. So we can see that we have the following. On the right, we have horseshoe kidney. So what is this horseshoe kidney? Normally, in embryology, we have the kidney developing in the pelvis and they ascend up to your abdomen, okay? So they start in the pelvis and they go up inside of the abdomen. You are like, cool story. So why this is important? Why I told you that they start in the abdomen, start in the pelvis and go up in the abdomen? Well, that means that if you have two kidneys, two functional kidneys, and they are stuck to their inferior pole to each other, and they are going up, they will get stuck under the first vessel they meet, which is the inferior mesenteric artery. They love to ask this. They will ask you, which vessel is preventing the kidney from ascending? And it will be the answer, inferior mesenteric artery. They keep asking this one. You must know it. Okay, so how can you take a look at a horseshoe kidney on a CT and be comfortable diagnosing it? So the moment you see a horseshoe kidney, well, in the beginning, I want you to appreciate the gross looking of it. It looks like this. And then, in case of CT scan, you will see the kidney going through the midline. The moment you see a kidney going through the midline, that's it, you have a diagnosis. This is a horseshoe kidney. So that's a horseshoe kidney. That's a horseshoe kidney. Okay, so if I show you this and ask you what is the name of this vessel, what you will tell me? What is the name of this vessel in red? IMA, not SMA. Remember, they stuck under the IMA. Okay, so the next thing. Okay, what about this vessel? What is this? Yes, excellent. This is the aorta, abdominal aorta. Good. So they write at the inferior wall of both kidneys fuse abnormally as they ascend from the pelvis during fetal development. Horseshoe kidney gets trapped under the inferior mesenteric artery and remain low in the abdomen. So you must know that they get stuck under the inferior mesenteric artery. Good. Kidneys function normally. Most of the time, not always, but most of the time, if they ask you, most likely the patient will have what? Nothing. But it has some association with other pathologies. For example, hydronephrosis. Why? Is it because of the horseshoe kidney? The answer is no. It could be due to urethropelvic junction obstruction. So if you remember when we spoke about the urethropelvic junction, it was the last portion of the kidney to get recanalized, yes? And thus, if you can take a look here, this look a little bit twisted because of the connection between the two kidneys. So it's a little bit also obstructed. So it's at higher chance of being obstructed and leading to hydronephrosis. Also, renal stones can occur because of the stasis, infection, and increased risk of renal cancer. They love to ask about this one. It has association with Turner syndrome most commonly, and the trisomy 13, 18, and 21. Guys, if I have an umbilical cord cross section and I look at it and there is 2 vessels, not 3, which disease does this patient have? If he have, excellent, everybody know it, Down syndrome. Good. Okay, good. Guys, you must know what is the name of this. There is a muscle here and they love to ask about it. Do you know what is the name of this muscle? It's called the psoas muscle. Okay, psoas muscle. Okay, so the next disease now is the congenital solitary functioning kidneys. What? Well, it goes something like this. Some diseases can happen in the baby and it can end up of giving you only one functional kidney. So condition of being born with only one functioning kidney. The majority of the patient are asymptomatic with compensatory hypertrophy of the contralateral kidney, which is like the other kidney. So one kidney will be really small and one kidney will be really big. Why? Because it has to compensate. Remember when we spoke about cellular adaptation? We said if you have to function extra, you either have to have hyperplasia or hypertrophy. Why? Because you want to exert more function. Thus, if one kidney gets obstructed, the other kidney becomes hypertrophied. So, but anomalies in the contralateral kidney could be common as well. So, what I'm telling you now, guys, is that if you have 2 kidneys and one of them becomes really, really small, the other one should become really, really big to compensate for the work. So, but anomalies in the contralateral one is common. It's often diagnosed prenatally via ultrasound. So basically some patient can have lack of a kidney. So you have unilateral renal agenesis, which is complete absence of a kidney. Agenesis, it means no making, yes? It's an ureteric bud fails to develop and induce differentiation of metanephric mesenchyme. A complete absence of kidney and the ureter. So let's think about this. So ureteric bud, guys, tell me please, which of the following structure comes from an ureteric bud? 1. Collecting duct. 2. Glomerulus. 3. Distal convoluted tubule. Okay, 1. Excellent. It's the collecting duct. So, the ureteric bud fails to develop So you do not have ureteric bud. And the ureteric bud made you a lot of the structures that um, led to the formation of the kidney. Remember also that the ureteric bud, I told you here that it was the one who induced the metanephric. Look, ureteric bud interacts with the tissue, leading to the formation of basically the glomerulus to the DCT. So without an ureteric bud, you will not have a collecting duct, you will not have a ureter, you will not have pelvis, you will not have calyces. In addition, the ureteric bud will not be able to interact with the metanephric mesenchyme. If that is the case, you will not have metanephric mesenchyme. So you will not have a glomerulus, you will not have a proximal convoluted tubule, you will not have lobe of Henle, and you will not have a distal convoluted tubule. You will have nothing. Exactly. Good. So, okay, next. So we have here the following. They write, ureteric bud fails to develop and induce differentiation of metanephric mesenchyme, so you will have complete absence of the kidney and the ureter. This is the first reason why you will have a completely dysfunctional one kidney, not two. So the next disease is multicystic dysplastic kidney disease, which is basically the ureteric bud fails to induce differentiation of the metanephric mesenchyme. So the ureteric bud exists, it's not absent, yeah? While in the unilateral renal agenesis, it basically there is failure of it to develop, so the ureteric bud itself does not exist. Here you have a ureteric bud, so you will have a collecting tubule and everything after it. So, it fails to induce the differentiation of the metanephric mesenchyme. So yeah, you will have a kidney, but it will be completely useless. It's a non-functional kidney consisting of cysts and connective tissue. And if I ask you something, these cysts will be formed from the collecting duct, or from the DST, or from the BCT. Yes, excellent. They will be formed from the collecting duct. Why? Because it's the only region that is forming from the ureteric bud. So it's a predominantly non-hereditary and usually unilateral, one-sided. Bilateral disease can lead to Potter sequence. Why? Because you will have oligohydramnios. Okay. So the next problem we have is something called duplex collecting system. Duplex collecting system goes something like this. The patient have two ureters. Or like two ureters, that's interesting. Yes, it's really interesting. So you can take, oh sorry. Yeah, so normally you have one ureter, but in this case you have two ureters from the same side. You are like, well, this looks fine, the patient will be totally healthy. The reality is the opposite. It's true that he has two ureters, but this is highly problematic. Why? Because one of these will be having high flow and the other one will have low flow. You are like, okay, let it have a low flow. What is the big problem? Well, when you have a low flow inside of one of these, that means the bacteria will love it. Why? Because the bacteria gets cleared out when there is high flow. So if you have a low flow, the bacteria will just ascend. Yeah? It will be easier for it to ascend and to be allonephritis because of the stasis. Excellent. So the duplex collecting system, it's due to a bifurcation of the ureteric bud. Why ureteric bud? Because these are the one who made you your urethra. You have bifurcation before entering the metanephric blastema, creating a Y-shaped bifid ureter, which has like two heads. So this tail of the Y, is like this. So this go to the metanephric mesenchyme or blastema, which is the same thing, and these are the two ureters. That's what it means by Y-shape. So duplex collecting system can alternatively occurs through two ureteric bud reaching and interacting with the metanephric blastema. In that case, it will not be Y-shaped. It will be basically two ureteric bud connecting to the blastema. Okay, it's strongly associated with vesico-urethral reflux, which we'll speak about in a moment, and urethral obstruction. So what is this vesicourethral reflux? Basically, when the urethra enters your bladder, it's entering in an oblique fashion. What do I mean by that? Take a look. If we speak about the connection between the bladder, yes, here it's the picture I was looking for. If we take a look at the area where the urethra is entering the bladder, normally it should be like this. It should be going down like this, okay? And normally when you get urine downward, it should be like this. And when you pee, after you finish, like you are stretching your bladder inward and you are peeing, this will shut down. And when it does shut down, you will not have a backflow of the urine. But in this case, as you can see, it's horizontal. It should have been like this, but now it's like this, it's horizontal. So it will not shut down. If it will not shut down, that means that when you like constrict your bladder, some urine will be going backward because it's straight into it, like horizontal. And the urine will be able to go up to the kidney, leading to hydronephrosis. Okay? So that's vesicourethral reflux. Remember, this can be in ladies as well, while the posterior urethral valve can be only in men, only in boys. So vesicourethral reflux and or urethral obstruction. Okay, so also the duplex collecting duct can lead to high risk of UTI because of the stasis. I hope it makes sense. The last point here, we have posterior urethral valves, which only occurs in men. This disease cannot occur in ladies. Please notice, if I draw for you, let me actually use this. Here you have the vesicourethral reflux problem. The posterior urethral valve, the problem is located where is the red box. Okay, the problem is here. So if the problem is here, you will have affecting a problem in one kidney or two kidneys. Yeah, two kidneys will have the problem because if the blockage is here, you will have more urine going back into the right kidney and also into the left kidney. While in case of vesicourethral reflux, it can be unilateral or it can be bilateral. Yeah? So, the posterior urethral valve, it's membrane remnant where? In the posterior urethra in male. So let's take a look at this. In the posterior urethra, you have a membrane formation. That membrane formation leads to an obstruction. So its persistence can lead to an urethral obstruction. Okay? So can be diagnosed by a bilateral hydronephrosis. So it's bilateral, two kidneys are affected, as you said. And the dilated or thick wall of the bladder on an ultrasound. Why the bladder wall is manipulated? Because it has so much urine inside of it. It's the most common cause of a bladder outlet obstruction in men. Remember, it's only in males because they have like a taller urethra. And it's associated with oligohydramnios in cases of severe obstruction. Why? Because they do not have formation of amniotic fluid. Just a general ideas now. Can you tell me, actually I will tell you. There is something called post-void residual volume. The post-void residual volume in men, and you must know these values. In men, it's 50 milliliters, okay? In ladies, it's up to 150 milliliters. So, if I have a patient whose post-void residual volume is 600 milliliter, that means that the problem is he having, let me test you, is he having a vesicourethral reflux problem, or is he having a stricture in his urethra, like a posterior urethral obstruction? Is it number 1 or number 2? Excellent, it's number 2. Yeah, because that leads to accumulation of the urine backward. Well, this one will lead to hydronephrosis, but it will not lead to accumulation of the urine inside of the bladder. Okay, excellent, you are getting it. Kidney is not as difficult as the heart. You will notice this. It's much more easier, make much more sense. The physiology might be a little bit difficult when you speak about the BH, but otherwise it's not that bad. Okay, actually, today is this Thanksgiving, but for friends, so Friendsgiving, and yeah, we will call it off in 2 hours for today. Tomorrow, not tomorrow, the day after tomorrow, we will come back and finish a lot of material. We have a lot to cover in renal. Renal will be a really interesting subject, short subject. I don't want to cover a lot of material in it today because not all students